मिनिमाइज करके वो उसमें से वीडियोस, हाँ डायरेक्ट वीडियो चलाइए. Sorry about it. Any presentation with videos is always number 2. Now look at this gentleman. And this is a patient I treated here in Patna. Look at his eyes very clearly. When he closes, it closes well. But when he's trying to open, it is not opening. Now this is an entirely different condition. Yeah, next. Next slide. Just, I think, do a manual override on that. So this is a person able to close the eye well, but unable to open. This is an entirely different condition called apraxia of lid opening. This is even more rare and often very obviously missed in apraxia. What is apraxia? It is non-paralytic motor abnormality. It's like writer's cramps. In writer's cramps, the person's hands, muscles, nerves, joints, everything is normal, but a person who was earlier able to write is unable to do writing, or even simple drawings are difficult. It has a difficulty in initiating the act of lid elevation after lid closure, but they can keep it open, like in that short video clip. It can be isolated or in association with BEB in up to half the cases. So I'll give you a simple example of this. If a person has apraxia of lid opening and is walking along the road, and suddenly the apraxia strikes, the person cannot open the lid, and the next step will land in a wrong place and the person will fall. There's a risk of injury. And the patient may often use different tricks to help open the eyes, like grimacing, etc. We'll come to that in a very quick moment. Yeah. Now this is another condition which we often see, and that's called the hemifacial spasm. What is hemifacial spasm? Now look at this gentleman, for example. You see that one side has spasm, and which includes the lower part of the face. Next. Okay. So most of us have seen hemifacial spasm. It is again something which we are the ones responsible for treating this in many cases. Unilateral, involuntary, paroxysmal, tonic or clonic contractions of the facial muscles. It is triggered by action like talking, eating. So for example, if patient has a history, you don't see it, ask the patient to squeeze the eye and it will trigger the hemifacial spasm. These are caused by clear-cut mechanical issues, like something compressing the seventh nerve, like a vascular loop. And all these patients of hemifacial spasm, I would like to emphasize, all patients of hemifacial spasm must undergo imaging. Lubricant drops, tinted lenses, stress reduction are some of the common preliminary treatment. Now we quickly come to botulinum toxin and a very quick overview of surgery. Botulinum toxin is magic for most of these patients. Effect starts 3 to 5 days, lasts few months. Inadequate response is seen in imprecise injection, wrongly done. Apraxic patients do poorly with Botox. Worsening disease, immune resistance, and there are only few contraindications. 90% patients of BEB will improve. So there is no place for a randomized controlled trial. It's a great drug. First line of therapy for HFS. In ALO, less effective, higher doses and shorter relief. So some of these patients need surgery. Side effects and complications are rare. These are some of the spots where we give the botulinum toxin. Time does not permit me to go into the details of this. Suffice it to say that well given, I think we have to override. And then we quickly come to a couple of, that's video 4, 5, 6, 7. Now this is the gentleman we first saw the benign essential blepharospasm in the driver by profession, virtually homebound after botulinum toxin injection. It's magical. So this is something, so as ophthalmologists, we must not send these patients with just lubricants. We must treat them. Okay, next. Video 5. Okay. Okay, it's just brief clips, no? We don't have time so much. So this is a patient with hemifacial spasm. Video 5. Yeah, look at the hemifacial spasm. How socially embarrassing it can be for this lady with the winking happening. Next. 6. Video 6. And this is following the injection. I'm trying to stimulate her facial nerve and cause her to have hemifacial spasm, it doesn't happen. So this is the kind of response that these patients get. So we must take care of these patients. Next. वीडियो नहीं, उससे पहले वो यहाँ PPT एक सेकेंड के लिए. Just a couple of more slides just to show what kind of response we can get. Surgical management. Surgical management is limited to those who are not responsive or not candidates for botulinum toxin. What does it involve? Removal of pretarsal, preceptor and orbital orbicularis oculi so that the protractors are weakened. So no muscle, no spasm. And muscle does not regenerate, it can only hypertrophy. So surgical management is also very, very effective in over 90% of the patients. Of course, this is extensive. So you're removing entirely the whole muscle plane of these patients' eyelids. So there can be hematoma, lymphedema, ecchymosis, exposure keratitis, lid malpositions. But if done well, these patients have a magical recovery. Next video. This is again, I don't think we have time for the video. 8 दिखा दीजिए, 8, 9, whatever. इसके बाद Now look at this lady. She has benign essential blepharospasm of such severe nature that she used to live in an old age home, virtually confined to her room. Food used to be brought to her, and she was absolutely of no service to society, in her own words. Next video. 9 child. And this is the patient after orbicularis oculi removal of all the protractors, day 1 after surgery. There's little bit of ecchymosis, etc. But she went on to become a volunteer in the old age home she was in, serving food to all the people, and absolutely independent of any kind of help and useful member of society. So this patient shows exactly the kind of results we can give with orbicularis myectomy and videos. अगले 2 videos दिखाई दीजिए. Now this is what I was telling about. This was a Nigerian town planner who came to me with this kind of a severe benign essential blepharospasm, apraxia of lid opening. He's showing you all kind of things with his faces. He's grimacing with an effort to try and open his eyes. He has to virtually lift his lid, and his wife used to hold his hands and bring him to my clinic. Next. In this kind of a patient, I did a surgery which is called as not only myectomy, but I also did a silicone rod frontalis sling. This patient later on came for follow-up by himself, completely relieved of apraxia of lid opening and benign essential blepharospasm, back to work. So this is the kind of result we can deliver to these patients, provided we diagnose and take care of these patients in time. Thank you very much.
Very nice presentation, sir. How do you go about this orbicularis myectomy? In this last case, Nigerian, you didn't prefer that?
Which one?
The last one, Nigerian.
In the last patient, I did both orbicularis myectomy as well as Botox he already had. And it was not making, because apraxic patients don't do well with Botox. I have seen people receiving, 50 units is what we usually start with. People have received 100, 200 units and are still not improving. So these patients are the ones who are apraxic. They will not do well with botulinum toxin. We need to give them surgery. And this patient, since he came from far away, I did both a myectomy and a frontalis sling. The logic of a frontalis sling is that it provides a manual override. So the moment the patient feels that the eye is not going to open, it's a very scary feeling for a patient, for anybody. If, for example, I close my eye, I can't open it, it's such a scary thing. But they can override it by just lifting up the eyebrow. Same sitting. In this case, I did an open sky frontalis sling. Same sitting. All around, and then hitch the tarsal plate. Obviously, it's a little scary because between the skin and the frontalis sling, there is nothing. Orbicularis is all gone. But he did well.
Sir, in case of hemifacial spasm,
Yes.
What neurological condition we have to rule out, sir?
Yes. Hemifacial spasm, you must rule out an actual lesion which is pressing on the facial nerve. The reason being that for example, a vascular loop is commonly found because with each heartbeat, the vascular loop presses on the nerve, there is demyelination and increased sensitivity. So that's the logic. You can have tumors as well, pressing on the nerve. You can have other lesions. So an MRI and an MRA are mandatory in patients with hemifacial spasm. So if there's something else, then the neurosurgeon needs to go in and take care.
Thank you so much, sir.
Yeah.